Okay, I'm having a little bit of difficulty in concentrating because of so many distractions here, but we're going to get through this. We're going to continue now with, I think I need the extra hand. So we're going to do this. Okay, so we're going to talk now the space of the neck, and I separate one group from the other. This one will be the carotid, the retropharyngeal danger space, and the perivertebral. And the perivertebral space is divided into prevertebral and paravertebral. And then we talk a little bit about the infrahyoid neck. And just to review, you remember you have the superficial cervical fascia, also called the investing fascia, that define the parotid and the masticator space. We have the buccopharyngeal fascia, which is the middle layer of the deep cervical fascia, and we have the perivertebral fascia, which wraps around the spine. So we talk about the carotid space. The carotid space receives contribution from the three fascia. The carotid space has a contribution from the superficial cervical fascia, contribution from the deep layer of the deep cervical fascia, and also from the buccopharyngeal fascia. And as you can see, it contains the jugular vein, the carotid artery, and cranial nerves 9, 10, 11, and 12, and also sympathetic fibers. So lesions originating from this space has to originate from one of these structures. And as you remember, the masticator space and the parotid space, they were related to the V3 and facial nerve. The carotid space is related to the petrous bone apex, the carotid canal, and the jugular fossa. So benign lesions of most of the tumors that you find in the carotid space will be paragangliomas and neurogenic tumors. Most of them will be schwannomas and neurofibromas. Occasionally, you're going to see meningiomas from the jugular fossa growing down into the carotid space. Malignant lesions, we're not going to talk much about that, except for the squamous cell carcinoma lymph node metastasis. They fill the carotid space. And then there are pseudo tumors and pseudomass like ectatic carotid artery, jugular vein thrombosis, and so on. Inflammatory changes, carotidemia, we're going to talk in the second portion of this discussion. At the very end, we're going to show some cases, and they're going to include carotidemia. What's really important is that masses in this space basically boils down to two types of masses. That would be the paragangliomas and the schwannomas and neurofibromas, usually of the vagus nerve. And you can see here a very vascular lesion with right at the level of the common carotid artery bifurcation. The smaller artery anteriorly is the external carotid artery, and the one posteriorly is the internal carotid artery. So this is the resident's favorite. They see a very intense enhancing lesion in this area. They know is the carotid body tumor, a paraganglioma. On the MRI, pre-contrast and post-contrast, they enhance very avidly. And you can see the artery, external carotid artery and internal carotid artery, and right at the level of the bifurcation, you see the lesion. They talk about the salt and pepper appearance. The salt on the pre-contrast will be pretty much the dark area, and the pepper will be the very dark area of signal voids. I don't see that too often, and they say that in order to see salt and pepper appearance, you have to have at least 2 centimeter size tumor to do that. I can see here some signal voids on the post-contrast, Here the salt is the tissue that's enhancing the pepper are the dark vessels. These lesions are very hyperintense. And when you do angiogram or MRA or CTA, you're going to see a very intense enhancing lesion at the level of the carotid artery bifurcation and with the characteristics of very intense flow, and on the early draining veins is not uncommon as part of that vascular change. The other area where you can see a tumor in the carotid space is higher up. This is a paraganglioma of the carotid space, and you can see that there is anterior displacement of the parapharyngeal space, which is normal on this side and is pushed anteriorly on that side. This is a glomus veigali. And the glomus veigali, as the other ones, are originated from the same type of cells. They are very vascular, and on the angiogram, this is the very intense enhancing lesion. And the reason we do catheter angiography is for pre-embolization prior to surgery, to cut down bleeding during the procedure. And usually it's the ascending pharyngeal artery, which is the first or the second branch. Here is the thyroideal artery, and the inferior, the ascending pharyngeal artery is the supplier to the tumors above the carotid bifurcation. And that includes tumor of the jugular fossa and the tympanic cavity. So these lesions arise from the non-chromaffin paraganglioma cells, and they are classified according to their location into carotid body tumors or glomus carotideum. This is the most common, and they don't have a big supplying artery for embolization. They recruit vessels from the adventitia of the adjacent arteries. Glomus tympanicum is the second most common. Glomus jugulare and jugulotympanicum is the third. And glomus veigali that I just show you is the least common of all these. And it's very interesting. This is a very rare tumor of the head and neck, less than 1% of the tumors. And there is a female preference, 3-to-1. And 2/3 of them are diagnosed between age 40 and 60. 2 to 10% of them are multicentric in non-familiar. So in non-familiar situation, if you see one paraganglioma, look for more, and quite often we see multiple paragangliomas. Now, the familial cases, more than 50% are multicentric, and they are autosomal dominant. So when you diagnose that in one member of the family, you look for the other members of the family. They are not exclusive of these three locations that I discussed. We have seen that in the larynx, we have seen that in the trachea, we have seen paraganglioma also in the mediastinum, and obviously in the spinal canal, in the region of the cauda equina, hypervascular lesion, that area, one of the differential diagnoses includes paraganglioma. Here is the ascending pharyngeal artery, which is the major supplier for all the other paragangliomas except for the glomus carotideum. The other tumor that is very common in this location would be the neurogenic tumors. Usually will be a vagal schwannoma or neurofibroma, almost invariably always pushing the carotid artery anteriorly because the vagus nerve runs behind. And you see here the internal carotid, the external carotid, the tumor behind it, and the vein pushed back there. This patient had multiple neurofibromas, and in the same vagus nerve, I see at least 2-3 more. And this patient went to surgery, ended up with the vocal cord paralysis because during resection they had problems in dissecting the nerve. In fact, this is easier to dissect because they grow at the periphery of the nerve, not as the neurofibroma that goes inside the nerve. So usually it's very easy to just peel this off. On the MRI, You can see pre-contrast and post-contrast. Behind the artery, you see this bullseye appearance, which is very typical for neurofibromas, neurogenic tumors. The other tumor that you will see in this location here is another paraganglioma, another neurofibroma displacing the carotid artery anteriorly, intense enhancement, but if you do the angiogram or CTA, you'll not see any vascularity as you see with paraganglioma. So that's a major way to differentiate one lesion from the other. The other thing you're going to see in this location, something happened here, is a very vascular lesion in the carotid space with the same intensity as the adjacent carotid artery. And if you see a very vascular lesion like that, don't biopsy it. If you biopsy it, you call your lawyer because this is going to be a problem. This turned out to be a, now we go. This turned out to be a very large exophytic aneurysm of the carotid artery pushing right into the bifurcation right above. It looked like a paraganglioma, very vascular on the CT, but this is a definite large lesion that you don't biopsy. And here is another condition in the space, which is a thrombosis of the internal jugular vein. And if you look, that thrombosis goes all the way into the jugular fossa, transverse sigmoid sinus, all the way intracranially. And you can see that on the coronal and sagittal plane, and this is a venous thrombosis. So these are the pathology that happens in this space. Also, dissections is always a consideration. Also, you're going to see lymph node metastasis, in this case from a supraglottic laryngeal tumor. And these are the common things that happen in that space. So if you know the content of the space, you narrow your diagnosis very, very nicely. And most of the time, you'll be right in your diagnosis. The retropharyngeal space is the next one that crosses the hyoid. Like the carotid space, it goes all the way from the skull base to the base of the neck. And what happened here, this is defined by the retropharyngeal space is subdivided by the alar fascia into retropharyngeal proper and danger space. So this space is located between the middle layer of the deep cervical fascia and the perivertebral fascia, and then subdivided by the alar fascia into retropharyngeal space proper and danger space. And there are a multitude of possibilities for this area, but most of the contents are fat tissues and few lymph nodes above the hyoid. Below the hyoid, you don't see lymph nodes in the retropharyngeal space. The other things are very intuitively, you can make the diagnosis very easily. What's important is that it's located anteriorly to the longus collis and longus captis muscle. So a lesion in the retropharyngeal space, danger space, always will be anteriorly to the longus collis and longus captis muscle, which are right here. And they usually have this butterfly configuration. And very common problem in this space are infectious processes. Like this patient had adenitis of the retropharyngeal node of Rouvier. This is not an abscess, it's a very swollen retropharyngeal lymph node. And very frequently, because this retropharyngeal space is very loose connective tissue and fat, it accumulates fluid very easily. So never mistake this for a retropharyngeal abscess. So on the sagittal view, you see marked thickening of the retropharyngeal space in another patient that had a lymph node infection from drainage from infected palatine tonsils. And this is the normal right carotid artery. On the other side, a very, very narrow internal carotid artery. When you see that, the reason for that is vasospasm. I don't know how many times they consult vascular surgeon to evaluate this child with possible dissection. They keep asking, do I give vasodilator? Do we do angioplasty? Nothing. There is nothing to do. It's just spasm, and when the inflammation subsides, this return to normal. So you can always assure the clinician that nothing's to be done. Here's the retropharyngeal space filled with fluid. You can see it better on the sagittal image. And another patient with a large abscess in the retropharyngeal space. Look again, the carotid artery is narrow on the left and normal on the right. This one is a drainable abscess, as opposed to the first one, which was just adenitis with a very inflamed retropharyngeal node. And you can see that it goes up and down because of this peripheral enhancement. You're now forming a well-defined capsule that is drainable. And here's the carotid and the other carotid. This patient had a very acute episode of chest pain. He came to the emergency room and they diagnosed acute myocardial infarction. They gave TPA. He arrested. They did intubation on emergency basis. And then he had difficulty in breathing and difficult with all kinds of problems, hypotension. We did a CAT scan, and you see here a huge retropharyngeal hematoma from the acute TPA treatment. And that's something that can happen in this space. This lady had a pelvic surgery and a very difficult intubation. 3 days later, she developed odynophagia, fever, and a lot of leukocytosis. We did a CAT scan of the neck, and you see pockets of air. This was a perforation of the esophagus, and the infection got into the retropharyngeal space. And from there, it went down into the danger space and dissect all the way down to the mediastinum. So this extensive abscess and phlegmon all the way from top to bottom. Now, in the same area, you can see tonsillar abscess and with a well-defined capsule. This is drainable. If you don't have a good enhancement in the wall, and you tell the surgeon that there is a retropharyngeal adenitis with abscess, they're going to dry surgery, and they're going to be very upset. So we always be very careful in calling abscess when it's only adenitis. And what happens is that usually the infection starts in the tonsillar fossa, it drains to the retropharyngeal node. From there, it becomes an abscess which ruptures into the retropharyngeal space, and you end up with this butterfly configuration of a retropharyngeal danger space. You cannot separate one from the other. There is not a clear membrane separating these two spaces. Other things, a lot of patients post-radiation to the neck, they developed, in this case, for example, a tremendous amount of edema in the retropharyngeal space. Don't call that abscess. This is lymphangitis following neck radiation treatment with stasis of lymphatic tissue and the fluid accumulating in the retropharyngeal space. It's very easy to say that this is post-treatment because you see very small submandibular glands due to post-radiation adenitis. You see thickening of the platysma. You see striation of all the subcutaneous tissue, classic for that. The other situation where you see retropharyngeal fluid accumulation is in the jugular vein thrombosis. You can see that in patients with anasarca from hyperproteinemia, congestive heart failure. So be very careful. This is not uncommon finding, and you have to distinguish this from abscess. This patient had a superior vena cava syndrome, and you can see all the collateral vessels bypassing the occluded jugular vein and superior vena cava. And you look here is a large mediastinal metastatic tumor from the lung, causing this superior vena cava occlusion and stasis of the lymphatics and vessels. Look the walls, how striated and edematous they are. Now we're going to look at the perivertebral space. And the perivertebral space, as I said before, is confined by the deep layer of the deep cervical fascia, also called the perivertebral fascia. It goes from one transverse process, cross all the way over to the other side, and then go over into the spinal process and back into the transverse process. You'll see that the external cladomastoid, the omohyoid, and the trapezius are not involved. They are not part of the perivertebral space. You can see that is the superficial cervical fascia or investing fascia in red here that goes and wrap around these muscles. So this space is very important. I'll show you a little more detail because it includes the vertebra, the spine, the vertebral artery and vein, and the longus collis and longus captis muscle. And you can see here, this is the prevertebral space, and posteriorly is subdivided into paravertebral. So the perivertebral space has two components, the prevertebral and the paravertebral component. And the longus collis and longus captis muscles are there, and the perivertebral fascia, cervical fascia, surrounding it. So these lesions are located behind the longus collis, longus captis muscle. It includes the brachial plexus. Here is the anterior scalene muscle, middle and posterior scalene, and the brachial plexus from C4 to T1 goes right through that. It gives the ventral rami and the dorsal rami. The ventral rami goes into the brachial plexus. The dorsal rami will innervate the posterior paravertebral musculature. And when you look at a lesion like this, between the anterior scalene and the middle and posterior scalene, usually you cannot separate the middle and posterior from each other, but clearly you can separate the anterior scalene from the other two. A mass located in this location, solid mass, can only be something related to the brachial plexus. And this, on the MRI, is a typical neurofibroma of the brachial plexus, displaces the anterior scalene anteriorly, is brighter on the stir and enhanced with contrast. And very clearly, you look here the anterior scalene and posteriorly the middle and posterior scalene. Between the two is the tumor. And as you remember, this is the scalene triangle. Behind the anterior scalene, you're going to see the anterior carotid, the subclavian artery, and anterior to the scalene is the subclavian vein. So anything that's above here is part of the brachial plexus. Usually it's the superior, middle, and inferior trunks. Sometimes you see multiple lesions, like in this case with neurofibromatosis. This patient had neurofibromatosis with bilateral neurofibromas. Here is the anterior scalene, here is the middle and posterior, and a dumbbell-shaped lesion going to the neuroforamen on that side, another lesion here, and at multiple levels you had multiple lesions. And again, you locate this tumor in the scalene triangle. Here's the anterior scalene, middle scalene, and right at the bottom will be the the subclavian artery. One important feature is that the longus collis, longus captis are displaced anteriorly, okay? And In this case, for example, I had the lipoma of the anterior perivertebral space, and here the right longus collis, longus capis displaced anteriorly. On the left is in normal position. You can see that it touches the bone, so it has to be within the perivertebral space. On the MRI, T1 is a bright like a fat, and this is a classic presentation for a lesion in that space. This patient is a 13-year-old girl with a vertebra plana. You can see that this is associated with a mass that is not only affecting the C4, but is also extending into the tissues laterally to the left side. And you can see here that the anterior scalene muscle is displaced anteriorly on the left side and is in normal position on the right. So this is a Langerhans cell histiocytosis. Now, if you see a tumor that's eroding the bone, it has to be in the perivertebral space. This is classic, and there's no question. This is turned out to be, in this case, a metastasis from lung carcinoma. This other patient had this tumor in the perivertebral space, and the tumor is invading the bone here, and is bilobed. And on the sagittal view, you see the tumor here, destroying C3 and C4, displacing the nasopharynx anteriorly. On the MRI, you see very bright signal on T2, on the axial coronal, and you can see the muscles being displaced anteriorly, the longus collis, longus capitis, densely enhanced match, very bright on T2. The diagnosis here will be chordoma. Most of the chordoma are in the sacrum, about 35% in the clivus, and about 15% along the spinal axis. And here's the chordoma. It's a rare malignant neoplasm that arises from the notochord remnants. It can occur anywhere from the skull base to the sacrum. 50% are in the sacrococcygeal area, skull base 35%, in the spine, along the spine 15%. It affects men more than women. Peak incidence is 50 to 60 years old, and it's uncommon in children, but when you diagnose these in children, they are usually very aggressive tumor. And the other condition I want to discuss with you is this patient that presents with odynophagia, low-grade fever, and a lot of neck pain. We did MRI, and you see this thickening of the prevertebral space with edema, and there's a low-density abnormality signal here, and you can see it here, and you can see the edema in the retropharyngeal space, but there is abnormal longus collis muscle on this side, enhancing with contrast compared to the other side. On the CT sagittal image, look how thickened is the prevertebral space soft tissues here. Normally at this level, it should be no more in thickness, more than half of the anteroposterior dimension of the vertebral body. This is almost the entire vertebral body. Below the larynx, then you can have the same distance and thickness of the vertebral body, because here you have to add the esophagus. So in this patient, you see a calcification right at the longus collis muscle, which is enhancing, and it's edematous. Here's the calcification, and diagnosis is longus collis tendonitis. When you see that, that's classic. It's acute calcific prevertebral tendinitis. Calcified retropharyngeal tendonitis is also the other name they call, but I like to call longus collis tendonitis. It's an inflammatory condition due to calcium hydroapatite deposition in the longus colli tendon. Neck pain, more or less fever, odynophagia, dysphagia, and this disease is self-limited. It resolves by itself. Now, in the posterior paravertebral space, you have this lesion that is predominantly lipomatous lesion with some calcifications. We did a biopsy of that, turned out to be liposarcoma of the paravertebral space. And here's another case of a lipoma, and here's a case of a very aggressive tumor. We did a pre-surgical embolization. The tumor is vascular, and this turned out to be a synovial sarcoma. Okay? We also see other lesions, such as abscess in this case. And here's the post-contrast with enhancement and the cavity there. And these are the things that happen in that space that we talk about the longus collis tendonitis, we talk about chordoma, but a bunch of metastases, mesenchymal tumors, they can all develop in this area. How much it have? So, in continuation here, we have, So the next short discussion I want to give to you is the infrahyoid neck. I wonder if you pay attention to the tracheesophageal groove. What's located there is the recurrent laryngeal nerve. Within the carotid space below the hyoid, you have only the vagus nerve. Above the hyoid, you have 9, 10, 11, 12, but below the hyoid, the only nerve there will be the vagus nerve. And then anteriorly to the anterior scalene muscle, you're going to find another nerve, which is the phrenic nerve. If you have a tumor sitting right on the phrenic nerve, you're going to have diaphragmatic paralysis on that side. And we have cases of brachial plexopathy, the upper brachial plexus. You remember C3, C4, C5 keeps the diaphragm alive. So when you have Herpes palsy with a traumatic lesion in the upper brachial plexus, you end up with diaphragmatic paralysis. And you can see that. If you look carefully, you're going to see that. Right at the tracheesophageal groove here, between the trachea and the esophagus, you see the laryngeal recurrent nerve. Sitting right over the anterior scalene, you see the phrenic nerve. And sitting right here within the carotid space is the vagus. So, laryngeal recurrent, phrenic, vagus. Okay? Now, this patient had a vocal cord paralysis. You see here the vocalis ligament and atrophy of the vocalis muscle. On the coronal, you see the paralyzed atrophic right vocal cord with a very prominent laryngeal ventricle. On the other side is a normal true vocal cord, and here's the false vocal cord. And this patient right here is the recurrent laryngeal nerve. What's causing the vocal cord paralysis is the tumor, very aggressive tumor, was a papillary cell carcinoma, extending to the tracheesophageal groove, leading to atrophy of the right vocal cord. If you are evaluating a patient for vocal cord paralysis, as you know, the vagus gives up the recurrent laryngeal nerve. On the right side, it goes under the subclavian artery. On the left side, it goes under the aortic arch. So left vocal cord paralysis, you have to scan all the way to the bronchial bifurcation, tracheal bifurcation. Have to go all the way under the aortic arch. I have cases of aneurysm of the aortic arch causing first manifestation was vocal cord paralysis. So these are the muscles of the paravertebral space, posterior, not going to go over each one, but I memorize it. I call on these ones are the MSS, is multifidus, semispinalis, and splenius, and on the lateral aspect here is longus capitis, longus cervicus, and levator scapulae. Now, the superficial cervical fascia is enveloping the sternocleidomastoid, the trapezius, and also contribute for enveloping the strap muscles. Then below the hyoid, in blue here, is the middle layer of the deep cervical fascia. We call that the buccopharyngeal fascia. It completely encircles around the trachea, esophagus, and thyroid and parathyroid, and also the recurrent laryngeal nerve. Now, the next fascia here is the perivertebral fascia. It contributes to the formation of the carotid space, and here's the carotid space, the visceral space, and perivertebral space. Now, what happens if the lesion is in neither of these spaces? For example, a lesion located here, you're going to have to call a lesion the anterior cervical space. Okay, and if it's located here, it's posterior cervical space. I'm almost done. And here you can see the retropharyngeal space, the prevertebral fascia, and between the prevertebral fascia and, and the deep buccopharyngeal fascia, we have the retropharyngeal space, and right here, I don't know what I want to say. You have the anterior cervical space, and you have the posterior cervical space. So if you look at a lesion like this, that lesion is located in the anterior cervical space. If a lesion is located here, is located in the posterior cervical space. It's not carotid, it's not perivertebral, so this is something to keep in mind. Both of these cases are lipomas. And that's the posterior cervical space. And as you remember, the anatomy is the foundation for everything. And I want to thank you very much.